The way to study blood pressure medication is to know the problem. It's okay. So your blood pressure is high. How does that happen? Well, it may be, so it may be, it's from the vessel. So you have a vessel that too much pressure is going through it. Maybe this is the nerves that supply the vessel. Either they're constricting too much, okay? So this is the vessel. And this is the nerve. Constricting too much, and that is making the heart, when it pumps, the resistance is too high. It causes too much resistance. Or it may be your kidney. Your kidney secretes other stuff that is involved in your blood pressure. Okay, and that is the renin, angiotensin, aldosterone system. And it also involved in water reabsorption. Okay, so that can increase your blood pressure. Of course, your heart. You got to pump, and there's receptors on your heart. Okay, there's like a beta 1 receptors, and then the pressure at which you pump against any resistance can increase your blood pressure. How fast it's pumping, how much blood is coming out, contractility, stroke volume, all of them can increase your blood pressure. And then finally, your brain. Your brain, there's receptors there that control your emotions. Okay, there's a alpha 1, alpha 2, mostly alpha 2 receptors that control the brain function and emotions and other things, and that can also control your blood pressure. And so these are the areas we want to tackle to control your blood pressure. And that's what all these medications are doing. It's just somebody sat down and said, okay, I can target this. I can target this. I can target this. When you have this problem, that tell you that, oh, none of them is effective. So we're doing all these things to control one blood pressure. None of them is effective. So you can, but you have choices, combinations to do. So we'll tackle each of them, and then we see which class of medications are there, and then how to recognize them. So the first one is ARB. ARB are very, it's slightly interesting, but very important medication. And I'll give you the pathophysiology, and you can use it to answer the question easily. So there's something we call angiotensinogen, okay? This is a protein. It needs to be converted into angiotensin 1. This is in the liver, okay? In the liver. So there's an enzyme that converts this to that. Then there's this angiotensin 1 need to be converted to angiotensin 2 by an enzyme that this occur in your lungs. Okay, the enzyme we know is called angiotensin converting enzyme. Then this angiotensin 2, what it does is it causes release of, it increases aldosterone. You go to the adrenal gland and increases aldosterone production. What does aldosterone do? Well, you already know that aldosterone will cause you to get rid of potassium. It causes your sodium to increase, so get rid of is down. It causes your potassium, sodium to go up, and water follow the sodium. This is how aldosterone increases the blood pressure. So it decreases your potassium, increases the sodium and water. And so that's what happens. This stage, angiotensin 2, okay? From this stage, there's another problem, something called bradykinin. This is involved in your airway. It can cause allergic reaction, and bronchospasm of your airway. It needs to be converted into inactive form by the same ACE enzyme. So by the same AC, angiotensin converting enzyme. So it needs to be converted. Otherwise, if you don't do that, this bradykinin will lead to cough and angioedema. You see what I've done? This is the side effect and complication of ACE and ARB. So let's say you're taking ACE. So ACE inhibitor, which is ACE, now I put an inhibitor here. We have an ACE inhibitor. Is going to block this. Therefore, you cannot make angiotensin 2. If you don't make angiotensin 2, no aldosterone. Therefore, your potassium will do what? So this is ACE inhibitor. Your potassium is rather goes up. It's opposite. So K go up. Let me use another one. So potassium goes up. What happens? Sodium goes down because we can't make aldosterone, and then water goes down. So this is how you're able to control your blood pressure. This is what controls your blood pressure. So that's the ACE inhibitor. So ACE inhibitor here. But then it also blocked this guy too. Okay, the same ACE. So I block you. If I block you, I cannot convert bradykinin to inactive form. I have more of bradykinin. And what does bradykinin do? It gives you cough and angioedema. These are the side effects of ACE inhibitor that they like testing for you. So hyperkalemia, yes, angioedema. These two are the one you need to pay attention to: angioedema and hyperkalemia. You know, when your potassium is too high, yeah, cardiotoxicity, yes. Angioedema is airway, so priority patient. Any patient on ACE inhibitor with hyperkalemia is my priority. ACE inhibitor, any patient taking ACE inhibitor, angioedema is my priority patient. Angioedema is the tongue, they will tell you the tongue is swollen, so swollen tongue, or their mouth is swollen, or they can trick you, they can say they have problems swallowing. That's a clue that something is blocking them. That's angioedema. If they don't use the word, you have to see the patient. Otherwise, that's severe bronchospasm. They will obstruct the airway and they die. The cough is nagging cough, is non-productive, but it's still also a priority because it can lead to angioedema. It's the early sign. So if they give you a patient with on ACE inhibitor with the cough, you need to tell the doctor that yes, I need is a priority patient. You don't ignore it, just a cough. ACE inhibitor cough is a priority. Otherwise, they develop angioedema. And so this is all the side effects about ACE, and that's how it works. So ARB is smart. He said no. I don't want to inhibit the angiotensin converting enzyme, this enzyme, because then I'll cause cough and angioedema. But I can go just a little bit and block the angiotensin 2 rather. So if I block this, there's no aldosterone, potassium will still go up, sodium go down, water go down, but I don't have cough and angioedema. So that is the ARB. ARB, same signs, but no cough, no angioedema. So where's the teaching point right there? You are on ACE and you're coughing. What do? You tell the doctor, what do you think the doctor will do? Put them on ARB. So ARB is a rescue medication for ACE. Anybody on ACE coughing, tell the doctor it's a priority patient for your test. Priority patient, and then let them change it to ARB. But they have the same side effect because it's hyperkalemia. So you got to tell them what? Don't take any food that's too much potassium in it. So no banana. Avoid banana. That's your teaching right there. SATA teaching right there. Okay. When you start coughing, let me know. When your tongue is swollen, let me know as soon as possible. That's your teaching right there you've given to the patient. Okay. So that's the how it works for ACE inhibitor. So this is the way it works, and that's the side effect that you need to know. The other thing is they are teratogen. So a pregnant lady, no. Pregnant, no ACE or ARB. You can't have that pregnant lady because the baby will be defected. So they are teratogens. You have to know that information. So once again, side effect, hyperkalemia, angioedema for ACE inhibitor, and cough. But ARB doesn't do that. How do you remember them? Okay, how do you remember them? They have the last name as Pearl. Sorry. Their last name is Pearl because that's what you have to know. Pril. And the ARB, their last name is Satan. So they can give you something like Lensil, no Pearl, or Lord Satan. They all sound the same. Start with the L. The one is Satan and Pearl. So Pearl is ACE inhibitor, Satans are ARBs. And that's all the side effects we talk about them. The diuretics, I just want to talk to them briefly. They also antihypertensive, but I think they work much better in CHF. So I don't see them as true hypertensive medication, even though they are the one they gave to you in the beginning to get rid of the water. And then if not, they give you a stronger medication. So there's two types. Everybody know hydrochlorothiazide. Guess what? Your test, they can put this one there because they know most people don't pay attention. It's Chlorthalidone. The way to remember them is the C and T. So it also has chlorothalidone, chlorothiazide. So that's how I can remember. If I see C and tally in between a medication with that hydro, I know it's a thiazide. So chlorothalidone or hydrochlorothiazide. Few things you have to know. These are sulfur drugs. I always try to teach as if to make sure science is connected. Sulfur drug, you're teaching right there without even going further. Sulfur drug, what do you teach them? Photosensitivity. And what does that mean? When you're going out, sunscreen, wear long sleeves, cover your head, so wear a hat to prevent sunburn. The serious part of sulfur drug is Stevens-Jones syndrome. And this is where they have small rash in the beginning, small popular rash in the beginning. If you ignore it, you'll be left with rash all over, and then they go into shock. So the early signs is a small purple nodule on their skin. If they give you a patient who is on thiazide or in any sulfur drug with a small purple rash on their body, that is your priority. You need to see the patient. Who do you see patient? That one. You're seeing them. Otherwise, they go in Stevens-Jones syndrome and they go in shock. The other side effect of thiazide, like all diuretic, they go into the kidney. Usually your kidney want to absorb water and get rid of potassium, okay, and sodium. So they go to the kidney and they say, look, I want you to get rid of sodium, get rid of water, and also get rid of potassium. So they causes low sodium, low potassium. So anybody on thiazide, you got to watch their potassium. This is one of the keyword in my B-sharp thing. Hypokalemia is bad for thiazide. But the other side effect is, I have an acronym for you to remember, is hypergluc. In addition to hypokalemia, which is number one. Number one is hypokalemia. So hypergluc means what? Glucose go up, so they can develop diabetes. Anybody on thiazide, you check their sugar is very high. L, their cholesterol goes up, lipidemia, hyperlipidemia. U, the uracil, uric acid, uricemia. And C is what? Calcemia. So if you're on hydrochlorothiazide, sugar goes up, cholesterol go up, uracil go up. So uric acid, they can develop gout, and then calcium go up. So that is hypergluc. Okay, for thiazide. So those are the side effects, and then a few things you need to know about it quickly. We talk about the vessel. I told you the vessel, okay? This is the vessel. These vessels have muscles, okay? They have muscles on them that contract, and the muscles need calcium. The same thing in your heart. There's muscles in them, okay? You have these muscles. Your heart is all muscle. Muscle, it's a muscular structure. That's your heart. It's all muscular structure. What does it need? Calcium for contraction. Well, if I block calcium in this, well, they won't contract. If the vessel, you block the calcium in them, what is going to happen? They dilate. So they dilate. So if you're dilating, you're pulling blood into the vessel. You're increasing the capacitance. So the capacitance of the vessel. So you get bigger and blood stay there. And look at what I'm going to do. These are signs and symptoms on your SATA question. If I have too much blood in the vein sitting there, or artery sitting there, what do you think will happen? Flushing. What is going to happen to my skin? Warm. So your face is all flush, your skin is warm. That's the side effect. Okay. If blood is pooling in my leg and sitting there, I get edema. I get I get edema in my leg. So my leg, all the fluid sitting there just like that. Okay. Your bowel, there's muscles there too. They cannot contract anymore. If your muscles can't contract in your bowel, you stool cannot move. So no peristalsis. They develop constipation. Of course, I'm decreasing your fluid, keeping all the blood in the vein and nothing going up in your heart to push it back. They develop orthostatic hypotension. These are all for the vessel. You see what I've done, deduce everything from there. If I go to the heart, well, the heart can contract, well, your heart rate goes down. This is why we use this for heart rate, okay, AFib and other things, calcium channel blocker to decrease your heart rate. Okay, most of these medication come in a extended release or sustained release. That's your fundamentals right there. Let me mention it. So extended release, sustained release. What is your teaching? Your teaching is don't do CC. Calcium channel blocker, don't do CC. What does that mean? Calcium channel blocker is C and C, but don't do CC. No crash, no chill. If they have sustained release, otherwise they have profound side effects. These are examples of them. There's the common ones are the dipines. They have nefe dipines, amlodipines. Verapamil is on its own, and the thiazide, but they are classic that you won't confuse them with other medication. Verapamil, thiazide, thiazide. But as soon as you hear the word dipine, this is the classic calcium channel blocker. Dipine is a calcium channel blocker. Okay. Now we're still on the vessels. Okay, we got to make this is the vessels. And then this is your, so we have artery and vein. These are the powerful medication. So they dilate, they make these guys bigger so that they can hold more blood and blood stay there and it doesn't go to the heart. That's all they do. So they are arterial and venous dilators. They dilate all of them. So blood sits in your vein and your artery. It doesn't go to your heart. And that's how they decrease your blood pressure. Okay, that's how they decrease your blood pressure. Blood pool there. And so the same symptoms is the blood in my sitting in my vein, not doing the doing nothing. They get warm, and you get also can get flush. And when you stand up, all of a sudden you get orthostatic hypotension. So that's the teaching you're telling your patient to get up slowly. If you're taking this, well, you cannot take Viagra, okay, Sildenafil. Any vasodilator will make you really bad. They cannot take calcium channel blocker either. You do the same thing. So you can't take calcium channel blocker because it's going to make your symptoms really, really, really worse. So don't do that. What do you think? Blood can also stay in your head. Your head, there's vessels in your head. So they get headaches. So those are common side effects that you're going to see. Okay. And so those are the things you can deduce from what they do. So when they give you a question, you're thinking about it. There's specific symptoms for each of them, things you need to know. Of course, if you check my CHF medications, nitroglycerin, I mentioned that. Okay, nitro, there's things you need to say about it. Avoid light sensitivity. Okay, so they cannot keep it in their car. Okay, they have to keep it in the same box. The refill is 6 months, not every month. They get 6 months supply and come back 6 months. Orthostatic hypertension. Okay, you tell your wife you cannot take Viagra. Okay, these are the teaching you give them specific. Nitroprusside, the chemicals in it, it has a lot of cyanide, so they get cyanide toxicity. I'm just saying this one in case they ask you. When we're in medical school, they like asking that. Always we get nitroprusside. Side effect is that is common for it specifically is cyanide toxicity. The reason why we like this medication because it dilate the artery and the vein. So guess what? Hypertensive urgency. When your blood pressure is greater than what? 200 systolic. So hypertensive emergency, and you have blurred vision, and you have nosebleed, This is hypertensive urgency. So what do you see? This is the patient you have to see. Blood pressure problems, systolic greater than 200, blurred vision, nosebleed, hypertensive urgency. You need to see this patient. This is a priority patient you need to see. These are the medications we can use to treat them, bring their blood pressure right away because they're very powerful. You don't bring it all the way down though. You want to bring it to like 170, 150, 170 range. Otherwise, they will stroke and slowly taper it. Okay, so those are very powerful vasodilators. Now we go into the brain. Okay, in the brain, I told you there is this receptor. If this is your brain, we have like beta, alpha 2 receptor. These control your emotions. It tells your brain to fire into the vessels, to relax, and therefore they're very good medication that you can use in blood pressure. Okay, they are in brain. They're central acting. So central acting, and I'll put as I go, I'll put some of the key things you have to know. Central acting. So need to know central acting medication can make you drowsy. Okay, drowsiness. So it can make you drowsy. But that's what they do. They're very good. Okay, they calm you down and they decrease your blood pressure. So that's how. So your heart slow down. So your stroke volume decrease, your heart rate decrease, and your blood pressure decrease. The cardiac output also decrease. So that's how they're able to do their work. Example is clonidine. I put this in red because all these medications can be used in patient in ADHD because it can keep calming them down. They are no more erratic. They can pay attention. They can focus. And so they're very good. You can also use it for anxiety. So guanfacine, it's very good. They have good therapeutic effect in patients with ADHD. Even though you can give it in Adderall, sometimes some people think guanfacine is an Adderall. They do different things. But just know, if you give you example, they don't give you Adderall in the patient with ADHD. You can choose guanfacine, even clonidine. That also because of the effect on alpha 2 agonist, methyldopa. So those are key things you need to know about this medication. Because they're very powerful and acting on your brain, you cannot just turn them off. So slow taper, okay, slow taper. And it causes orthostatic hypotension because of the central acting. Because of this, these medications are taken at night, especially clonidine. No, at night. Always, when any medication that is taken in the evening, the good answer should be bedtime because that night is different. Everybody time is different. So bedtime. And then one thing you should know, I don't think they pay attention that much, but in case you see it, alpha 2 agonists, clonidine, guanfacine, and methyldopa, anybody in the liver disease cannot get it. They will go into liver toxicity. And things that you see in liver toxicity, such as their bilirubin goes up, their AST goes up, their ALT goes up, and the albumin goes down. I just want to put it there so that you know. So liver toxicity. So that's what they do. And that's their side effect. That's how you can recognize them. These are alpha 2 agonists. The alpha 1, if this is your vessel, okay, if this is your vessel, they basically attack the vessel directly. They say, I'm coming for you. If this is the vessel, there's nerves there. So these nerves that act on alpha 1. This is your main vasoconstriction. This is what causes vasoconstriction. And this is where norepinephrine and epi go and bind to and causes your blood pressure to goes up. Well, if I block this, then your blood pressure goes down. So these are the alpha-1 blockers. Okay. They're very unique. Okay, they're very unique because this is your prostate. Okay. When your prostate is big and the urethra is coming down, going to the penile area, it push on that and you cannot pee. So you have dribbling, you have urgency and frequency of urine because the urethra is being choked. Luckily, there's alpha-1 receptors on your prostate. What a lucky idea. So if your blood pressure you have blood pressure problem and you have BPH, where if I block your alpha-1 on your vessels, it makes your blood pressure goes down. Guess what? I'm blocking your alpha-1 too, and you get better, and you start peeing easily. And so these medications are good for patients who have hypertension and BPH. And the way to remember them, I don't even look at the first name. I call them Zosins, even from medical students, Zosins. I see them, Zosin, I know that any patient who's on Zosin, they tell me, oh, I'm taking this for my prostate. I said, yeah, I know, but your blood pressure, it also affects your blood pressure. So they expect them to have hypotension. Because they cause profound vasodilation, they lead to orthostatic hypotension. So orthostatic. And this is your teaching. They take it at bedtime. That's a testable point. These alpha-1 blockers, the Zosins, take it at bedtime. Otherwise, they will fall. You get up slowly. Okay, that's your teaching right there. Slowly, slowly, slowly. Otherwise, you're going to fall down. Expect them to have dizziness. It's okay. That's and they faint. So you teach them all these things. Teach them. But remember, these medications can be used for prostate and control your blood pressure at the same time. So they're very good for that. So that's the alpha-1 blockers. They are not agonists. Now, let's spend some time on this guy. So this is your heart. And you have beta-1 receptors here. Your lung, you have 2 lungs. So you have 1 lung, you have 1 heart, and 2 lungs. Okay. Here's the trick here. So you have beta-2 receptors. Okay. These beta-1, if something act on it, like norepinephrine, epinephrine, they speed your heart. So they ask for contraction, okay? Beta-2, the reason why we put it on your lung is to causes dilation of the airway so that air can pass through on the smooth muscle. So that's why you give somebody albuterol, which is a beta-2 agonist. They bind to this and dilate it, who has an asthma. Well, unfortunately, if you blocking this, you got to find something that will block only 1 or only 2, okay? If you block beta-1, the heart rate slow down, okay? The blood pressure go down. You decrease stroke volume, and then you decrease oxygen demand, basically. So this is what beta-1 blockers does. Beta-2, which are on your lungs, if you block it, guess what? Bronchospasm. You don't want to block beta-2 receptors, okay? So somebody have hypertension and you want to give them a beta blocker, the next thing you ask is, do you have an asthma? Okay? These guys, BAM, I call them BAM, B-A-M. These are beta selective, so they bind to beta 1 only. These guys at the bottom, they said, no, I don't care. I'll block everything. So they block B1 and B2. So you don't give, if somebody has blood pressure, hypertension, and you want to give them a beta blocker, you better have give them what? Beta 1, because then that act on the heart directly. If you give anything that block on the beta 2, it causes bronchospasm. So I call it BAM is safe in asthma. So BAM, if you give them any medication that has a BAM, they will be good in asthma patient. If I'm blocking, I give you a beta blocker. That is a BAM. That block your heart. There is no bronchospasm. Now, if I give you nothing like BAM, like this ones, then I'll get bronchospasm because they are non-selective. They bind to B1 on your heart, but unfortunately, they block B2 and it causes constriction. The way to remember them is law. They have law at their last name. They have law, bisoprolol, atenolol, metoprolol, and that is the BAM. B-A-M. That's the BAM. The other ones, the same thing. They have last name, but they are not BAM. So propranolol, nadolol, and labetalol. So the way I remember is I just remember BAM. BAM is B1, is safe in asthma. If anything is not BAM, then it's non-selective and it causes problem. It causes problem in this patient. So that's the things you have to know about the beta receptors. Because of that, there's a lot of teaching involved, okay? A lot of teaching. And so because of what we've described, there's certain things, precautions you have to give this patient. So precautions. This is where they ask you, they like beta blocker because there's so many questions they can ask you on it. Well, if somebody is an asthmatic, don't give them BAM. Be careful. So look at the medication they're asking. Somebody with the beta blocker, look and say answer choices. And if it's one of the BAM, is safe. If it's not one of the BAM, so they give you a question. It says somebody is asthmatic, is on propranolol, is my patient, is priority. I'm seeing the patient. I will question that management because that will cause the patient to have bronchospasm. So I need to see that patient. The other thing is diabetic patient. So that's why this is very highly testable point. So what I like about the diabetic patient is what happens if you're diabetic. The number 1 risk for you that we check is we want to prevent hypoglycemia. Okay. And what are the symptoms of hypoglycemia? Palpitation, anxiety, dizziness, diaphoresis. That means you're sweating. You look like you're having panic attack. Basically, all this is signs of stress. Your body is secreting hormones, the stress hormones, to tell your body, we need more sugar. But this is all the effect of beta 1 receptor because the norepinephrine is acting on this and it's telling your heart to pump. So your heart rate goes up, tachycardia, all this is from beta 1 receptor. And that is the norepinephrine acting because you're hypoglycemic from the stress. Guess what? Any patient on beta blocker, this effect doesn't happen. So it marks the effect of hypoglycemia. Because of that, you need to be careful on the patient who has diabetes and is on a beta blocker. because when they are hypoglycemic, the effect will be masked by the beta blocker, and you will know. So you have to teach them to be really careful about it. The other thing you need to teach your patient is you cannot stop it right away. So you need to wean them off slowly. Otherwise, they will have reflex tachycardia. And of course, the bronchospasm. Okay. So that's one is related to the asthma. You got to tell them bronchospasm. Some of the key things that you may ask is heart rate less than 60, and then blood pressure 100. If somebody is on a beta blocker and a heart rate is in the 60 or blood pressure is 100, don't give it to them. So on your test, heart rate 60, blood pressure 100, and it's on beta blocker, you need to hold it. So if a nurse give a patient with a heart rate of 60 with beta blocker, it's a priority patient, you need to intervene. And of course, you block the heart so they can have AV block, so they can bradycardia. So any patient on beta blocker, the heart rate is very important. They get the AV block and they can go into cardiac arrest. So you have to watch them carefully and carefully and carefully. So this is all I can provide, and I hope I've explained myself and giving you the key points. I think the key point is the asthma patient on the BAM is safe. They cannot be on propranolol. Diabetes on beta blocker, you got to watch, teach them, be careful about maxing the effect of hypoglycemia. And then the regular side effect is bradycardia. So check their heart rates. If it's 60, you don't give them the beta blocker. Take care of yourself and good luck in your exams. Visit my website on YouTube channel and subscribe so that I can grow my channel and Facebook. Take care of yourself and keep charging.